Good morning, good afternoon, and good evening. Thank you everybody for joining us today. We're about to begin. This is Jobin Abraham from Resolve to Save Lives, a global health organization that partners with low and middle income countries to prepare for epidemics. We have a distinguished lineup of speakers to discuss a very critical issue that we need to work on together: the effective use of public health social measures in Africa. Your presenters today are Womi Iteng from Africa CDC and Amanda McClellan from Resolve to Save Lives. To offer their guidance and remarks, we also have Zabulon Yoti and Ambrose Talisuna from WHO Afro, Dalia Samhorai from WHO EMRO, and Tom Frieden from Resolve to Save Lives. With that, let's welcome Womi to offer his opening remarks. Womi.
Okay. Good morning, afternoon, and evening, everyone. I'm happy to join this session and also share experience from the Africa CDC. As a continental center for disease control, our work is largely around prevention programs, supporting member states in Africa to build capacity to detect also early and also respond as quickly as possible and contain it, essentially driving the saving life agenda. We have a bunch of experts in the team, not just within the center here in Addis, but also across member states and regional offices, actually. And our work for the pandemic at the moment is to support countries that are yet to find, very few countries are yet to find cases, but also those who are already responding to the pandemic, to support them with logistics, technical expertise, and everything that is required to quickly contain this pandemic. And one area of work that has emerged is the non-pharmaceutical interventions, which is what we are here to discuss. And we'll be sharing with you what we've done so far, the guidance, promoting it and supporting. And we're happy to take questions on how implementation can happen and how quickly we can work together to contain the pandemic. So I welcome colleagues, co-facilitators, and everyone out there. Thank you.
Excellent. Thank you, Womi. Dr. Talisuna.
Good morning, good afternoon, good evening, wherever you may be. You are really welcome to this interactive session where we look at public health to try to contain this outbreak continent. As you really know, the window of containing COVID in Africa is quickly closing down, and in the absence of the vaccine and therapeutics, we're really going to discuss now could have a role in delaying the spread and the cases and what has been described as spreading the curve. So this session we're really going to have is very, very important. And I think non-pharmaceutical interventions should be implemented, taking into consideration some other issues that could have impact on how successful they are. And I hope that this session will be addressing some of these issues. And we really have a panel of discussion for us for this session. And as WHO Afro, we are very happy to have partnered with Resolve to Save Lives over the last couple of years in terms of building capacities for HR and also trying to strengthen how we contain the outbreak. With the lockdowns, of course, virtual sessions like this are going to become the order of the day. And maybe when we quickly contain this outbreak, we'll have what we will call a COVID legacy. So I welcome all of you, and I'm more than glad to contribute. Over. Thanks.
Thank you, Dr. Talisuna. Dr. Samhorai?
Thank you so much. Well, it's Dr. Samhouri, not Samhorai. Thank you very much. Thank you very much for organizing the session and for everyone who is joining us today. I think in the Eastern Mediterranean region, we have 7 countries that are part of the African continent, if you want. And at the moment, the level of transmission of the virus is pretty much varied between these 7 countries. The majority of the countries have already started to implement some non-pharmaceutical interventions, and the magnitude of these measures is pretty much big, and the consequences can be also, I wouldn't say devastating, but can be pretty much hard on the different communities. There are many questions that are being asked by countries on when exactly right to start implementing the non-pharmaceutical interventions, and what exactly the level and the magnitude of implementing those measures. Will these measures be implemented by themselves or in combination with other measures? And the biggest question that we usually receive is when exactly to relax, and what is the procedure that should be followed to relax those measures. I certainly hope that those number of questions will be discussed during this webinar, and hopefully we can come out with an initial guidance that can be of use to the different countries and that can really help them in the implementation of different measures. But the most important thing is how to make sure that the consequences of these different measures are, one, understood, and two, having solutions or alternatives to address those consequences. Thank you very much again, and I certainly hope that this will be a very useful session for everyone.
Excellent. Dr. Frieden.
Thank you very much, and it's wonderful to be here with you, even virtually, from New York City, where we are really facing a terrible outbreak right now at this moment. I would like to emphasize that we really are all in this together. This is a global battle against coronavirus, and we need to learn from each other and work with each other. Speed is essential. To give you an idea of how important speed is, in New York City, we already have more than 1,500 deaths, and the number will increase much more than that. It's a huge number. In just a few weeks, it's more people than die from our leading cancers. This is a huge challenge. And if there had been a 2-day further delay in implementing the physical distancing interventions, the caseload, the hospitalizations, the intensive care need, and the deaths would have doubled. And by the same token, if we had started 2 days sooner, it would have been half, because we had a 2-day doubling time. Prioritization is essential. You can't do everything. So doing the most important things immediately and well is crucial. Being organized well is essential. Having an incident management system, having a structured response, task tracking, and basing actions based on data, taking action based on data and feedback is crucially important. Where are cases? How are they spreading? How much are they spreading? How are the contacts being tracked? What proportion are being tracked regularly? When is the time to tighten the tap? And when is the time to loosen the tap? 2 days ago at Resolve to Save Lives, we released a draft for discussion for people to try and see what works. We released a draft to say, here's the concept. It's not just about sheltering in place and waiting for this wave of cases to crash over us. It's about starting the process right now to strengthen our capacity to track the virus, strengthen our capacity to strengthen our healthcare system so that we don't get so overwhelmed and we can protect our precious healthcare workers and prevent them from getting infected, because we're seeing that all over the world, but it is preventable, and strengthen our capacity for critical care. And then in public health, how to scale up testing capacity. Let me just ask everyone to mute your phones if you're not speaking, and whoever may be able to mute you from his side. But from public health, we need to be able to scale up the testing capacity, the case isolation capacity, the contact tracing capacity, and the contact follow-up and quarantine capacity. This is key. If we can contain or suppress, we'll find cases and quickly reduce spread from those cases so it doesn't explode. Once it's exploded, you have to really shelter dramatically for a long time, 1, 2, 3 months for the cases to come down. But then you can't just go all back out again. You have to gradually loosen the tap, let the less vulnerable people leave first. As you're tracking cases, as you are strengthening healthcare, and as you're doing really effective contact tracing and isolation. It is not possible to overreact to this threat. We're talking about the possibility of 10 million deaths globally. That is a plausible outcome here. It is possible to react inappropriately. And what we're seeing all over the world is, as political leaders and finance leaders see this huge problem, they take one look at public health and say, oh, that's too complicated, and they try other things. So we need to get public health in the game to understand this is the way forward. These are how we can do physical distancing, which is a better term than social distancing, because physically we need to be apart, 6 feet apart or 6 feet under. But socially, we need to be together. We need solidarity. That's crucially important. And so we are very honored to be partners with many of you and to learn with you as we go down this unprecedented road. None of us have done this before. And we need to learn from every country what is the best of what they've done: the tracking, the isolation, the testing, the contact tracing, the physical distancing interventions, the social support. And we need to, in real time, share those lessons, not just the technical and scientific lessons about how the virus is spreading, but also the lessons about what works to implement control measures effectively in each of our communities. And it will be different in different communities. So thank you very much, and I look forward to hearing how the rest of the webinar went.
Excellent. Thank you, Drs. Samhouri, Dr. Talisuna, and Dr. Frieden for those opening remarks. Before I hand it off to Womi to present the rest of today's presentation, just a couple of remarks. We want this to be, while there are about 200 people on this phone call, we want to make sure that this is as interactive as possible. So as our presenters are speaking, please find the Q&A section in the bottom of your screen and enter any of the questions that you may have. We will have specific sections assigned to where the panelists can address your questions. So please keep entering your questions as they come to mind, and we will try to do our best to get those questions answered during the Q&A period. And so it looks like we have a lot of people from the NGO sector, and as well as good representation from the African government official side, from WHO and Africa CDC, and from academia. We have quite a diverse set of an audience today. And now that we know who is joining us for this conversation, I will hand it off to Womi to take us forward in the discussion around the guidance and evidence for implementing public health social measures. Womi, please begin, and I will advance the slides on your behalf. Womi?
Okay, so thanks, Jobin, for that. Can we have the next? Okay, Jobin, can we go through the agenda quickly? Everyone, welcome again. It's Womi from Africa CDC, and our discussions will go through the guidance we currently have from the Africa CDC, some question and answers from everyone who is in here with us, and then effective use of social measures. We have colleagues from Resolve to Save Life to go through that. Then we have question and answers, and we're happy to close the session and plan for the next time. Next, Jobin. Okay, so as soon as we started seeing that clearly the outbreak in China wasn't limited to China alone, it was growing in scope. We saw in Europe and very early at some point within Africa. One of the thinking was, how do we quickly learn from the settings in China and what was happening at the time in Europe, and then plan here in Africa so we can implement appropriately. And just to say, this is an area for non-pharmaceutical intervention. It's an area where we are learning, we are building as we are learning, and we are growing through the science and the operations as well. So it's as much as we're sharing what we've done, we are hoping that this awareness session will also trigger some thoughts from everyone in this community to start contributing to the science in the near future of how we can implement social measures, and as Tom Frieden had rightly described, physical than the social distancing. Okay. And for Africa CDC, we've published a policy guidance on community physical distancing. At the time, we used the name that is really common within everyone, which is social. But as we continue to discuss it, we realize that physical suits better than the social, because we want to maintain the social communication, even though the physical part, the physical aspect needs to be dealt with. So why is physical distancing important for COVID? We've learned from previous outbreaks, including even the Ebola outbreak in 2014, that for infectious disease, there is a limit to what clinical settings can do, what the primary public health expert can do. There's need to carry the entire community, both from the population side and the community in terms of governance, and then make sure all of government is involved to take measures that align to clinical management, that align to psychosocial support, psychological support, to handling tensions on the streets that epidemics or pandemics as this will cause. And yeah, so this learning had really triggered what we felt was a very good a measure implemented in China, at least to delay the epidemic at the time from the outbreak from spreading into other regions, and also slow down the epidemic, to give chance actually for public health measures to the health system not to be overwhelmed. So just to speak through what we suggest for physical distancing, transmission occurs frequently among those who have close contact with family members, workplace colleagues, and others. We also see that it happens between those who are yet not symptomatic. So it's difficult to say who is infectious at the point or not. So this is really why the physical distancing is encouraged, and is a very effective measure to consider when we're talking of containing or managing the current pandemic. And then transmission also occur across settings, in public places where people are yet to even know that they have symptoms. Jobin next. So this is probably one of the important illustrations to demonstrate the rationale around why social and physical distancing is important. One, it helps to reduce the height of the epidemic, so the health system is still able to absorb the pressure that comes from the outbreak. The other part also is that it delays the epidemic, so it gives enough time for planning, for learning, and also saving lives. Shall we have next? And this allows for three critical things. One of them is the health facilities are not overwhelmed, so we're able to manage those who are infected with available resources or some such capacity to augment that. The second aspect is to build for public health officials to be able to apply new knowledge and learning. So there's opportunity, if the system is not overwhelmed, to learn geographically from one part of the country to another, or one part of the continent to another. And also that it gives chance actually for the researchers to look into what treatment and vaccine measures will look like. And just to mention one very important thing is that when we're talking of public health interventions, you agree with me that prevention it's the way to go. It's safer, it's cheaper. And for a disease like COVID, where we are yet to have vaccines or cure for it, the only prevention opportunity we have is physical distances, distancing, and this emphasizes the importance of what we are discussing this evening. So when do we implement social distancing or physical distancing? And this is one question we've received across different settings. And the advice will be when there are reported cases or deaths that are not detected within a previously known chain of transmission. And also to consider that population must have been sensitized. There is also an accountability framework for social and political considerations. You want to look at other things that will cause tension and panic among the population, which you want to avoid. And then also you have to, whatever it is, in any setting, you have to think of adaptation to local context. And to answer the how question, how to implement the public health social measures, you have to think through the use of complementary measures simultaneously. It's very important because we've learned from the China experience and also from previous influenza outbreak pandemics that putting in place more than one measure at a time complements the efficacy or the effectiveness of your program. And so we recommend that you look through what needs to be done at individual level, what needs to be done at community level, and what is the cost implication, cost benefit for any of them, and roll out simultaneously. The second aspect, when you're thinking of the how, is to implement within the most limited geographic unit. And this is particularly important because you want to measure the impact of your success. You want to make sure you are implementing these measures very strict or very loose within a context where the population would easily understand with you, the government or the stakeholder leading the program, why it is needful for them to participate. And then the third part is to think through full respect for human rights and dignity. We've seen in previous experience where social measures cause a lot of tension, and we see and then they are not sustainable very early, so we lose the impact of such intervention. So we need to be mindful of implementing them alongside respecting human rights and dignity. Okay. And one critical thing for a lot of public health intervention is to think through what the community involvement is, and this is the community engagement. So it's important to think through involving stakeholders. You need to map your stakeholders to avoid social disruption and to avoid some negative impact that would then cause violence and negate the entire essence of the measures that were implemented to save lives. And thinking through this, there are 4 areas to look at. Make sure community is carried along, identify the community gatekeepers, especially we've seen faith leaders very leading this in the front burner, especially when they are carried along. And then we have the establishment of monitoring system, including two-way communication. So as we're monitoring from the public health or from the government perspective or those leading the program, we also need to think of communicating back and also listening to what the community is saying, setting up a framework or a process for feedback from the community, because this again allows for flexibility and improvement of the measures that have been implemented. And the third area to think of when mitigating negative effect of these measures is to provide countermeasures to reduce the negative impact. So think through what their tensions are, what their fears are, and how can you augment, for example, survival, food programs, basic needs, housing needs, and a lot of other things that can be easily implemented. And then always think of adapting to measures. We've seen some kind of rushed decisions around quickly implementing the measures. And in the past, we've seen them having negative impact. So think through what the current situation is and how the community, what are the laws in place, what are the authorities on the ground, which agency needs to be involved, who needs to be carried along, who needs to be contacted. So this is all about the adaptability component for mitigating negative impacts. Next. And for physical distancing, we look at it in two areas. One aspect is what can I do as an individual? The other aspect is what can we do as a community? So for the individual perspective, stay at home if you're not feeling too well, if you're unsure, if you don't have any critical need for going out. This you can do on your own. The other part also is avoid mass gatherings. For example, schools, church, mosque, going to parties, weddings, and any place where you'll be exposed or be in contact with a lot of people at a time like this. Then the third component is to avoid close contact, even when you have to stay with people. For example, workplace colleagues, responders like me are all in the field. A lot of us have to be in an office space, but we think of how do we maintain some distance away from colleagues so that we can stay healthy and alive to support, to lead the work that we've been called to do and save lives, essentially. So from the community perspective, and just to look through what the evidence for social measures have been, we think through contact tracing, isolation of sick individuals, quarantine of exposed individuals, and we've seen that in terms of evidence, looking through literatures in the past or some reports in the past, there's not so much evidence around how effective this has been, but we've also looked at it across three other evidence and then three other areas. The second is the resource intensity, how much of resources is required. And with every plus, a plus is very low, double plus is low, moderate, and then very high. So in terms of resource intensity, contact tracing, isolation of individuals, and quarantine is in the moderate. We've classified it in the moderate, and we have potential negative impact somewhere also in the moderate. Resource intensity actually in the high. And then for legal and ethical considerations, we have that as low in terms of evidence. And then for personal public health social measures, which is now where we feel every committee member should take responsibility for, we've seen that there's a lot of evidence for this. So as you're thinking of what can the government do or what can those out there do, we've seen by evidence that a lot of what you can do as an individual actually has more evidence in terms of what the outcome, the effectiveness will look like, and it's cheap. So at the individual level, we can take quite effective measures, moderately effective measures, and at almost no cost. And then negative implications are really very low, and legal implications don't even exist. If you wash your hand, for example, no one will come and hold you and take you to the court or to face any authority to say you've done the wrong thing. So we really, this is driving the point that that personal consciousness and responsibility is really critical to containing the COVID pandemic we're currently dealing with. Next. And we see from the community level, we have, this is where now the government have to come in, or communities need to agree that, okay, we have to make sure we close educational centers, we have to make sure special populations are taken care of or removed from risk areas, and then mass gatherings, cultural events, sporting events, and festivals are managed carefully. And in terms of number, you want to either completely close out such events or manage the number of people who attend. And then there's a cordon sanitaire, which is really around a quarantine and closing off buildings or whole of residence area This can be within a street, within a city or a region, and we've seen that in several settings, even within Africa. And the essence is to limit contact between high transmission areas now and where we don't have or very low transmission areas. And some countries are doing this, and we've started seeing early results. Next. So thinking through what the community measures, if evidence for community measures, surface object cleaning, UV light in crowded places, increased ventilation, school measures, closure, avoiding crowded settings, cancellation of events, no matter how important they are. Again, we have very little evidence around this from previous learnings. In terms of intensity, if you remember the slide around for the personal, you see that a lot of the indicators here we are tracking, it's on the high side, moderate, and it means resources. It involves a lot of funds. It involves a lot of resources, personnel, to make sure these interventions are implemented. And then there's relatively higher level of negative impact on the community. It can raise tensions. It can cause violent protests around the communities, and this is really not what we want. And then the legal implications and ethical considerations that are needed are really between low, moderate, and some of them are high. So overall, as we're thinking of implementing community social measures, we should look at what evidence exists, how much resources is required, and then what are the legal backings that are available to support what we plan to do, and how quickly can we plan this, what are the potential negative impact of these measures, and this will provide the basis for when and how the measures should be implemented. Okay, next. And to summarize, public health measures, social measures, vary in resource intensity and resulting social and economic disruption. So we need to think of how much of resources is required and how much impact will it have. Is there evidence for what we want to do? Have we adapted it to local context? What are the things we need to do? Do we need to implement 3, 4, 5 of them? Do we need to implement some at a time and then others follow as we learn along? Do we need to expand the scope? How long should we do this? All of these areas are things to consider. And it's based on what is in any context, what is my local disease transmission dynamics? What's the clinical capacity to manage severe cases where they occur? What is the impact of social and economic disruption, including the vulnerable people, as we've seen with the COVID, the aged, and those who with comorbidities? And then how do we maintain essential services in a manner that the population will not rise against the intervention, and then we then lose the sustainability of the intervention and ultimately lose the opportunity to save the lives that we initially would always want to do. Okay, so this is where I will stop, and I'm happy to take questions around what the guidance from the Africa CDC is, and any conversations on how to implement, when to implement, and any of such. Thank you. Joe Binova.
Thank you so much. LJ, do you have the questions lined up for us?
Sure. Thank you, Womi, for such an excellent presentation. We have quite a few questions in the Q&A session, and to get started, there are a few questions on how to implement these NPIs in limited resource settings, and how do we prioritize what interventions to implement first, particularly the resource-intensive interventions.
Okay, I guess this is summary of the questions. Okay, to look at how I think really we need to think of what evidence is available for what do we really want to do, what is the scale, where are we with the burden of the outbreak. Are we still expecting cases? Are we still dealing with imported cases? Are we having local transmission? Are we having large communities? So need to think through all this. It's never early. It's never early, but at some point it can be late. So think through where you are in terms of the epi curve, the epidemiology, the geographic extent of the outbreak, and also think through what the impact will be on the society. Where do we stand? For example, if elections, especially in African setting where you have elections maybe a month or two from now, what are those things you want to put in place or keep back from implementing that will not send the wrong message for the government in power? And then you start seeing maybe opposition and some other political players trying to use what was intended to save the population to then cause crisis in the society. So we need to be mindful of the setting. We also need to be mindful of where our public health system, do we have enough treatment facilities? And if we do, how much do we have workforce? All of these things need to be put in place, and really adaptation.
Great. And for how long do we implement these measures, considering the poor socioeconomic status of many of the communities in Africa?
Okay, thinking of how long, really, it should grow, and it shouldn't be on and off per se. You should think of the escalation of the interventions, and it should be based on, rather than how long, it should be based on the progression of the outbreak in your setting. It should also, it can leverage between your response and also the recovery process. But again, this is based on evidence. And remember, you need to keep it to where the impact will be much felt by the community. So you need to limit to where it is needed. And so you need to monitor what the indicators are saying, what the epidemiology and what the society, the feedback is, and what the health system adjustment program is in place to help in terms of resilience. I'll also allow Amanda to chip in if Amanda is from Resolve to Save Life, if there are areas she wants to add to those two questions.
Yeah, thanks, Wumi. I think the next part of the presentation will cover some of those questions, and so maybe we'll go through them in more detail and try to give some practical advice in terms of knowing when and how to manage those.
Just one more question around the evidence for the social distancing before we transition to that. A question from one of the participants: is the distance of 1 meter sufficient everywhere?
It's a really good question, and there's some evidence around increasing to 1.5. And I think there's been some questions around some of the new data around aerosolization. There's been a large super spreading event here in the US that looks like it may have come from singing. And so we will have a science review that will deal with some of those evidence-based questions that we can send out for people. But even getting 1 meter distance in some low resource settings, in crowded informal settlements and markets, is going to be a challenge. So at least 1 meter, but further if you can.
Thanks, Amanda. I think the key thing is 1 meter where you cannot, or as much as possible, be conscious of 1 meter. But I mean, as far as you can, please go ahead, even if it's 100 meters. Yeah.
And so as we transition into this next segment where Amanda will talk to us a little bit more about some of the nuances of what it takes to think about effective implementation of these strategies. Before we do that, I'll launch another poll just to get a sense of where all of your countries might be or teams might be in the implementation of public health social measures. Excellent. It looks like For the first question, how would you describe the use of public health social measures in your country? Most people, about 62% of people on the line, are in a country where public health social measures have been in place for 2 weeks or more. And the rest of the people are in countries where public health social measures were either introduced just in the last week or they're being discussed, with very few people in countries where these have not been considered or implemented at all. The second question is around which of the following best describes your country's current ability to monitor public acceptance for social measures? For this question, it seems most people are somewhere in between. We are not monitoring public acceptance yet, or we are periodically scanning social media, but could be more systematic, with some people already having some structured data-driven decision-making, and that's very good to hear. Number 3 is, which of the following support tools might your country benefit from the most? This was an option where you could select multiple ones, but it looks like that all 4 options are things that people are very interested in, with guidance and monitoring data for risk communication, information to support policymakers with decision making, and information about economic and food security impact being just a little bit more than the updates for the Emergency Operations Center. So with those insights, I will hand it off to Amanda McClellan from Resolve to Save Lives to lead us through the discussion about the effective use of public health social measures. Amanda?
Thank you so much, Jobin, and thank you to Africa CDC and WAMI. So one of the supports that the Resolve team is providing and thinking about in the background, along with many other people, is learning the lessons, like Dr. Frieden said. What are the lessons we're learning from China, Korea, from Italy, those countries that have been very heavily affected already, and how do they apply into low resource settings? And I think the big lesson for us from China is if you can implement all NPI, all physical distancing measures and public health measures at scale for 2 months, you can stop the outbreak. But it costs billions of dollars. It requires thousands and thousands of contact tracers. It required 10,000 more hospital beds and additional measures to support individuals at household levels. So to be able to achieve what the Chinese have done is extremely expensive, extremely resource intensive, and requires huge amounts of coordination at community level and individual level. So what does that mean for us in lower resource settings? How can we learn the lessons from China and South Korea to limit the impact of COVID-19 while still maintaining community cohesion and reducing economic and social impact? And so as Wami mentioned at the beginning, the whole idea of the public health and social measures is to delay the epidemic and reduce the height of the peak, with that red dotted line really being key there. You have to titrate or change the use of the physical measures and social measures depending on how much clinical capacity and public health capacity you have. And so one of the challenges right now, as Dr. Frieden said, speed is the key, making sure that we're increasing that system's capacity to be able to respond so that we can absorb cases and are able to tighten and loosen the public health measures to be able to titrate or to manage the number of cases that we have. What we have seen in countries and contexts is the mortality rate for this is very low if your health system can manage. We've seen very few deaths in Singapore, very low death rates in Germany, because they're able to manage the flow of patients and maintain good levels of clinical care, where we've seen in Italy, the health system overwhelmed with very, very high case fatality rates. So next slide. Thanks. So in terms of adjusting the public health and social measures to balance public health needs, it's really about using them in combination. As Wami said, we call it stacking. Which different measures can you use effectively, and how can you turn those on and off? Okay, a mix of individual measures and community measures adjusted to your epidemic dynamics and your community situation. To do that, you really need to monitor for effectiveness and the impacts, and that will help evidence-based decision-making for increasing or reducing the public health measures. Member states should be prepared to reinstitute the measures if cases start to increase again, balancing public health measures and social impacts. Now, the key thing here is you need to tell the communities that this will happen early. If you reduce public health measures and then in a few weeks you have to turn them back on, the community need to be expecting that. You don't want them to lose trust in the government or government agencies by saying, well, you said we were okay and we reduced them and now look, we have more cases. We have to be communicating early about multiple waves and using the MPIs or the public health measures that we have very carefully, turning them on and off, and really building that trust in the community to say that, you know, this is the plan all along. So one of the approaches for discussion that we've been working on here in the US, but also with our partners in Africa, is around the tightening or loosening of the public health measures. And you can see that top slide, turning on the measures very late results in a bigger peak and a longer time frame for really loosening those measures, and then having to turn them on again as we start to get more cases, loosening and tightening based on the public health capacity. But you can see that the use of early and moderated public health measures in the bottom, turning them on earlier, getting a lower curve, being able to reduce earlier. And then you can see there that the downward split, you have to apply less measures over time as the caseload is more manageable. So in terms of triggers, how do you know when to turn them on and off? This is really something that we want to work with everyone on. This is going to take learning and constant monitoring. So with Africa CDC and WHO in the next few days, we will share a document around potential triggers to turn these measures on and off. But what we're working on right now here in the US and in Europe is looking at reducing physical measures when you have a decreasing number of cases, but your lab testing is improving or reducing. So you're testing more and still finding less cases. Decreasing numbers of chains of unknown transmission, declining deaths, decreasing healthcare worker infections. It's really very key indicator that you have enough PPE and that your health system is managing. And so, you know, we've seen very high rates of healthcare worker infections here in New York, and in Italy and in other places. And so this is a key issue that we learned during Ebola. A number of healthcare workers infected and died, and we can't afford that again. Making sure that we have sufficient numbers of trained staff and PPE, even if cases double, that we have good hospital capacity, contacts are identified for all positive cases with at least 90% follow-up, and non-COVID health services are able to deliver adequate services. And we think this is a group of triggers that help us understand not just the COVID data, but the public health capacity. And if we're able to meet these, or at least the majority of these indicators, it's a good indication that we might be able to loosen off some of the social measures that we've put in place. In the reverse, we must be ready to increase them again or put them back on, stacking them. Take a few measures off, wait 2 to 3 weeks to see what the impact is. And if the cases start to go back up, be ready to reintroduce some of those measures. Or if the caseload is stable, continue to reduce the social measures again. But in terms of triggers for increasing, we're suggesting things around new case counts increasing by more than 10%, or 3 consecutive days with no substantial increase in testing. And we're seeing that a lot in the data. If we see caseloads increasing for 3 days in a row, exponential growth takes off in about 5 days. It's a good early indicator that your caseload is really about to take off. Obviously, doubling time is a really good indicator. So if the doubling time is less than 5 days, you should probably put more social measures in place. More than 3 unlinked chains of transmission within 14 days. If you're getting increasing healthcare worker infections, it's probably a good sign that your health system's overwhelmed or you don't have enough PPE and you need to protect that system and put more measures in place. You're getting more admissions than discharges for 3 consecutive days, a good indicator again that your health system is potentially at risk. If you don't have ICU capacity, now this is going to be a challenge in many African contexts with a lack of critical care and really a balance. And this is really, you know, it's going to be important that we understand the transmission dynamics in Africa, how in populations that are younger with different comorbidities to Europe and Asia, how much ICU capacity that we need. So we've left that indicator open, but an important one that we'll have to look at and develop over the next few weeks. An inability to follow up, sorry, Jobin. Inability to follow up contacts for at least 80% of positive cases if we don't have enough PPE. And really importantly, if our essential health services cannot be implemented safely. I think we all know and recognize the importance of measles outbreaks that came after big responses to Ebola, both in DRC and in West Africa. And so really being able to maintain access to malaria, access to antenatal and maternal care and services such as EPI. So how do we turn them on and off? This is an early graph, again, just trying to demonstrate the idea that go big and go bold in the beginning with your public health measures and then start to titrate them off, loosen them off, but remaining vigilant and making sure that we're able to turn them on and off, and should really be driven by not just the public health data, but the social science data. So we've started some of that work already, and part of today is to explain some of the work that WHO and Africa CDC with partners from London School and the private sector have been doing to try to help build a monitoring data set that will help countries use evidence-based decision making. And we recently ran some polls, some surveys in Nigeria and Ethiopia just to get a sense of what was happening. And I think the key message that came back is, you know, a great quote that said, "I might be protected from COVID sitting here in my house, but I will die of hunger." And this is really the choice that many of our communities are going to face if we implement public health measures in the same way that we've seen in Asia. Okay, so 65% of respondents said they didn't have a separate room in their home to keep someone isolated if they were sick. So a lot of our messages are stay at home if you're sick. But we have a lot more people in houses, the family sizes are much bigger, and often without a room to isolate. So how do we adapt that message and that measure to match the context that we're working in? 67% of respondents do not support closing religious settings, churches or mosques, although they're generally supportive of other closures. So how do we really engage with faith leaders early? We have seen some major super spreading events within churches and religious settings. So how do we manage that, make sure that we are giving other options like broadcasting religious services or having open air services? Over half of Ethiopians and Nigerians only have enough food and money to last 1 week if movement was restricted. So this idea that we could shut down large cities like Wuhan for 2 months won't work in many of the cities that we're working in, because people do not have the same access to services. There's no DoorDash home delivery like here in New York. I can get anything that I want delivered to my house without leaving. It's not the same in many of the cities that we work. So how do we change the lockdown rules to make sure that people have access to food and to funds? An example, 45% of Ethiopians would run out of prescription medication within 1 week. So how do we make sure that our very vulnerable populations, like our patients with non-communicable diseases, still have access to medication? How can we make sure that they have 3 months supply? How do we make sure that they continue accessing care? And so this is just a graph. We'll start to share this data next week. We will have data from another 19 countries. And so there'll be another webinar towards the end of next week or early the week after to show and share the results from this polling that we're doing. but essentially really looking at this data and understanding how the acceptability of different closures are being accepted by the community, but also understanding the barriers why. And so you can see here, 42% of people, support the closures of markets, but could only last a week without food. So how do we adapt the closing of markets? Can we keep the markets open but restrict different geographical areas to come day by day? So in Ethiopia, we've been talking about one worrier coming on Monday, a different worrier coming on Tuesday, so that we don't have mixing within geographical areas, for example. Next slide. One of the measures that we're trying to look at is this caseload on the top, and obviously the area under the curve is not scientific. This is a graphical representation. So I had some questions yesterday about areas under the curve. This is a visual representation of the cases on the top. So, what the caseload looks like without measures versus with measures. There's some good evidence from 1918, the last big pandemic, and some of the more recent SARS use of social measures that showed that countries that implemented non-pharmaceutical interventions or the public health measures early did suffer economic impact, but they recovered much, much quicker. And so one of the balances that we have within the low resource setting is how do we balance those economic losses and social disruption on the bottom against the public health impact and caseload on the top. And so how do we use monitoring data to turn on and off using not just public health triggers, but social science triggers and economic triggers to find this very fine balance that we're going to need to be able to ensure that we don't cause other humanitarian crisis by locking down whole cities, restricting access to food, loss of agricultural products and income. So one of the things we want to work with you all on and to learn together is how do we find this balance between economic loss on the bottom and numbers of infections and caseloads on the top, and what monitoring data will help us make these decisions. So we will send out after this webinar an evidence-based review. You've heard a lot of information from us today. A lot of it's included within the evidence review that we've worked on over the last few weeks, as well as the ACDC guidance. So all of the information you've heard around transmission scenarios and when and how to use the different MPIs within the different phases of the epidemic will be in a table like you see here. With more detailed information on the PDF that we'll send out after the webinar. So in terms of supporting the monitoring of public health social measures, I'll open it back up to the rest of the panel. But to enable to support you, we've created a partnership between Africa CDC, WHO AFRO, WHO EMRO, the World Economic Forum, the London School for Tropical Health and Medicine, Resolve to Save Lives, and a private company called Ipsos to really help us bring together all of the different indicators and data sets that we're seeing there that we think may be useful in a way to provide a decision-making dashboard and the different types of products that we think may be useful. Jobin, for the next slide. And at the moment, we're looking at providing 4 different products to support decision makers. One around risk communications, really targeting civil society and government decision makers with more granular data around rumors and misinformation that we'll be able to get from country surveys, but also from scraping social media and traditional media. A decision support for policymakers that will combine the epidemiology information and some of the triggers that we talked about with the legal and ethics of using social measures, as well as the social and economic indicators. This will go out via Africa CDC and WHO to the policymakers, politicians, WRs, ministers of health, really to help explain and guide decision making there. There'll be a specific document aimed at EOCs with response options. So how can you change or adapt the countermeasures to reduce the impact, and what should you be focusing on in terms of reinforcing your health system or public health, or adapting your social measures? And then probably probably monthly, because this data will not change as quickly, a brief from the World Economic Forum and the partnership around economic and food security impacts to help guide decision making and track negative consequences of COVID against those indicators. So I'll open it up to the rest of the panel and Dr. Ambrose in terms of next steps and how we move from here. But as Dr. Frieden said, and Wami reiterated, the evidence base around some of this is not very clear. The transmission dynamics in Africa are also not clear. There's a lot that we need to learn together, and that the effective use of monitoring data to inform evidence-based decision making is going to be really important. We really want to hear from you what you need and what you're seeing and what support we can provide, and how we can adapt these measures to the context that you're all working in. So maybe Dr. Ambrose, I'll hand over to you, and Dr. Dahlia in terms of next steps and any feedback.
Thanks, Amanda. Colleagues, as you can see on that slide, we have some next steps, and one of the things that we really want to do moving forward is to have additional sessions like this, which are focused on some of the technical questions you're raising and some of the results that we'll be getting from the work that Amanda has been talking about, because I guess this is uncharted waters for us in Africa. I think we have not implemented this kind of measures for probably of this magnitude. And you've seen that, for example, school closures happened before countries almost had cases. So we really need to be seeing how this will evolve and over time. The other is really to provide feedback on the products from the partnerships and to have an adaptive process of learning together. So some of the work that we are going to do with Ipsos and some of the work that Afro, for example, is interested in looking at the impact of these measures on essential health services. And you saw in some of the slides, a critical piece of work for us is really that the COVID response is important, and all these measures should be as aggressively implemented as possible, the epi measures, but also the social measures and the public health measures. But how that really impacts on non-COVID services is something that we need to be tracking. We saw this in the Ebola outbreak in West Africa. We had an increase in malaria cases, kids who are not immunized. So we need to be seeing how these things work, and generating that evidence and being able to share it as we move along will be nice, so that policymakers are informed and we can adapt our measures. You'll receive details from us and Africa CDC in the coming weeks on some of the work that we want to be doing together. So, we can now welcome a couple of questions. I've seen some in the chat room with respect to what is the benefit of masks for the entire population. And I hope that people will be getting some of the answers now. The guidance is changing, I think, over time. And you know, the original guidance was that masks are for sick people and health workers because you protect the population. But I think we really need, we need to be looking at the new evidence that is coming up. What is the proportion of asymptomatic and how are they infectious? So that is really the critical piece of why people are thinking that we might have to revisit the evidence of masks for the general population, because if the population of asymptomatic people is high and they are transmitting, we don't know. We can't isolate them because we don't know unless we have scaled up testing and we are capturing them. It becomes challenging to know who is asymptomatic and transmitting. And that might be the rationale for increasing the coverage of people who are using masks, because you might actually be asymptomatic people who are then protecting other people in the public. Over to you and to the question and answer session. Thank you.
Dr. Samhouri, please, if you have any comments.
Well, quick comments. Thank you very much for the very comprehensive presentation. Just a couple of main comments. The first one is that at the moment, really, there is not much of evidence that we can rely on, and we can take it as a blanket evidence that we can used to support some decisions, which means that whatever advices we're giving at the moment, it might change in the near future. And this is pretty much a general call for everyone to keep an eye on the new evidence that's coming out, the new evidence coming out from science. Tremendous amount of papers are being published on a daily basis, which to believe and which not to believe. This is also something that need to be filtered. My second comment is that the situation in countries is pretty much not the same, apart from the fact that we do have a different level of transmission of the virus, but at the same time, the public health capacity and the access to healthcare capacity, the number of people who are living under poverty line, the number of people who are basically unemployed, these are all major factors. And therefore, I don't think that we can give one. Which really takes me to the importance of risk assessment approach. Maybe something that we need to discuss in addition to the indicators that we should be coming out with to help countries to decide when to put the different measures, when to relax them, when to escalate them, in order to be able to have a balanced measures from a public health perspective and from economic and social perspective. I think a risk assessment approach always need to be conducted, and therefore maybe we need to come out with a tool that will help countries to do this risk assessment and to decide on the measures accordingly. At the moment, we're seeing different magnitude of measures, and particularly in countries that are having very few number of cases, and they really started very hard right from the beginning in terms of implementing the non-pharmaceutical measures or the physical distancing measures. We're not really sure if this is effective or not, and at the time where those countries will not be seeing cases, and therefore they might be relaxing those measures. If they decide to escalate these measures again, there might be a tense relationship between the government and the communities because they might not be able to take it more. So again, and not to repeat what Dr. Frieden said, is that the speed is an essence here. We really need to pull together all the evidences, if any, and to make sure that we provide the countries with the right advice. And this has to be country tailored, and we cannot provide a blanket to all countries. Over to you.
Excellent, thank you very much. And now we actually have about 15 minutes for questions and answers. And I'll leave it to our colleague, Lindsay Joseph, to tee up the questions for our panelists.
Sure, thanks everyone. For WHO, do you think that we need to, the question from the audience, do you think that we need to take a look at the IHR guidance, given that they have guidance in avoiding trade and movement restrictions? How should we modify that for this particular outbreak?
Shall I take this question, or Andrew? Can you just quickly repeat it? I want to just make sure that I got it right.
Sure. The question is, do you think that we need to take another look at the IHR guidance, given that there are policies about avoiding trade and restricting movements, particularly for this outbreak?
Okay, so at the moment, as everybody knows, that the IHR, as per the IHR, the recommendation that we have is that WHO is not advising the unnecessary travel and trade restrictions. But at the same time, it was kind of open to countries in a way that they really need to conduct their risk assessment and to decide whether specific measures need to be taken into consideration. Additional measures need to be taken into consideration. If those additional measures are taken by a country, they need to share this information with WHO along with the public health evidence behind having this information. So at the moment, there is a lot of evidence coming out, which means that it might support the country decision, but you need to take into consideration that the travel and trade restrictions also having negative impact on the countries in terms of economic. And at the moment, we're facing a big problem related to the global supply chain. We're not able to provide the supplies to countries that are in need. And therefore, I'm not really sure it's a point of discussion whether there should be a revision of the IHR, but it's really to look into carefully the Article 43 and how this article is being implemented in terms of its understanding and the measures that are related to it. At the moment, we are working on a document that basically addresses all of the consequences of the measures taken by countries in terms of economic, social impact on the different countries, and again, the biggest impact on the supply chain. And we're putting kind of options for countries to consider, but the most important thing, and this is the essence for each measure that is taken, is it has to be really taken by or based on a risk assessment approach. Thank you.
Yeah, I definitely want to agree with my colleague from EMRO. And it's really not an issue with the IHR. And the IHR Article 43, I mean, countries can implement measures beyond what is recommended in what we call the interim recommendation. The Director General, when he declares a public health emergency of international concern, also issues temporary recommendations. And those temporary recommendations, of course, were then based on the evidence that we knew about the disease then. And so countries have definitely implemented measures beyond what the temporary recommendations were, and they really based on a risk assessment and on the impact of the measures in terms of containment and mitigation. And we can see that from China and everywhere where all these measures have been implemented, there is a benefit. So I think the issue is that countries then just need to share those measures, and if WHO asks them to say the measures, why they're implementing those measures and the rationale for them. A document will soon be coming. We are working on it, on trying to lessen, to see how we lessen trade and travel measures. Of course, the biggest impact we are seeing on the African continent at the moment now is we can't deploy such capacity to some of these countries, and we've been trying to reach out using the mechanisms that we have, the heads of states and ministers, to see that there can be some exemptions for us to be able to surge in countries that actually don't have the capacity to respond, so that we can support the incident management support teams, but also the most needed supplies in those countries. We need to deliver those supplies. We need to deliver personal protective equipment. We need to deliver testing kits if we're going to do widespread testing. And so we are really trying to use available mechanisms to see that even in where there are real lockdowns, that countries can have some exemptions for these measures to be delivered. But by and large, the IHR is still a valid document. But I think the temporary recommendations are the ones, they were based on the evidence as we knew the disease then, and that could have changed. Over.
Thank you. Amanda, a couple of questions for you. At what level, national, provincial, or local, should public health social measures be managed, particularly when you adopt the on-off approach?
I think it's a really good question. I think the advice we're going with is the smallest geographical unit that you can. So the more local, the better. But we have seen in some cases where we have strict social measures in one location, and in a neighboring county or a neighboring region, we don't have those measures. We've seen a rapid movement of the population. So I think Paris is a very good example. Paris locked down very quickly and quite strictly. And the following days, we saw millions of people move out of Paris into rural areas to escape the measures and spread the disease even further. So the advice is the smallest geographical unit that you can, but considering the surrounding areas, and you don't want to drive population movement.
Great, thank you. There are quite a few questions about implementing physical distancing in slums and informal human settlements, and how that should be addressed.
Great. So I think the question here is really about how we can work with local community leaders to find solutions in those areas. Overcrowding in these areas is a problem for lots of epidemics. When we have cholera or other types of epidemics, some of the measures that we've seen traditionally work and were used effectively during Ebola was to isolate or provide space within these communities for people to go when they feel sick. So we think there's potentially two options here. One, providing space outside of those homes for mild and moderately ill people to self-isolate, and China used this very well. They created these very big stadium type hospital settings where people who were mildly ill that couldn't self-isolate at home could move to with care, but it is resource intensive and you need to provide food and water and communication support. One of the other options coming out of a group from London School is what we're calling shielding. And that's, instead of isolating people that are sick, isolating people that are extremely vulnerable. And so within these urban areas, potentially providing space for people that are old or with comorbidities or immunocompromised to be able to shelter together away from the rest of the population and protect the most vulnerable, meaning that we would have to provide support for fewer number of people. Now, this hasn't been tried yet, and there's some discussion around whether that would, how strict the measures would have to be if you did have the disease introduced to a group that is highly vulnerable, that you would see very rapid spread. But we think there's these two different options perhaps for adaptation, either providing additional space for people who are sick to isolate outside of those areas, and it's resource intensive, but has been shown to work effectively, or to isolate the vulnerable and protect the most vulnerable to the disease.
Can I jump in here, if you allow me? And thank you very much, Amanda, for elaborating on these two options. But I think the issue is it's really broader than this. And if we take some of the countries in the region here, where you have the different categories of population, like migrants, refugees, and internally displaced population, and those people some of them might be living in tents, and some of them are living in camp or camp-like settings. And I think there is a major issue when it comes to the physical distancing and then maybe access to healthcare. And maybe this is a thing for all of us to think about in these conditions, how we are going to guarantee this physical distancing. I mean, adding an additional space might not be even feasible. So I understand that we have a big number of audience listening to this webinar. I think innovative ideas will be really good to collect. And this is something that we can take on board to advise countries on this. We've really been receiving this kind of a question from several countries, and we understand there is a lot of players on the ground in terms of NGOs, different organizations that are providing services. So it would be good to come out with different options that can really help those camp setting, or like the camp-like setting, or even tents if you want, because it's not really easy to implement it on the ground, the adding of additional space. Over to you.
Great. Thank you, Dr. Samori. Another question from the chat. What should be the priority actions of government if communities start having negative community impacts from the implementation of NPIs, such as violent protests?
Okay, let me Wami here. Let me provide some context to that. I think primarily what is important just before implementation is to make sure communication and community involvement in the process is it's active. So that will proactively take care of the negative implications of the negative impact of the measures. However, we know that it can't be so perfect. No matter how much you communicate, there are opportunities where you still have nuisance in the system that want to make the system difficult to implement. So really is to have build an early warning system. Your indicators for monitoring should be sensitive enough to inform how when tensions are beginning to rise, so that you deal with them early and deal with them specifically. So specifically will be, where is it happening? How do we, rather than meting out punishment, but how do we engage with them more actively? And what population, what's their what's the issues about, what's causing the tension. So you need to identify very specifically what is the cause and deal with the issues as it's about to grow out of proportion. So these are areas to consider in managing any negative impact that the measures might have as we go on with implementation. Over.
Yeah, Lindsay, maybe just to add to that, I think it's a real possibility and something that we have to take very seriously, that we will see violence and protests. We have seen some very difficult incidents already in Kenya and in Senegal, not just from the population, but from authorities. So we have seen in some locations, police overreacting to social the lockdown orders and beating people or arresting people, and we have seen some incidents where church services or mosques have been closed down and the pastor has been arrested and then the population has rioted. So this is a very real possibility and something that decision makers have to really think through. And really emphasizes the importance of engaging with community leaders early and consistently and really developing that feedback mechanism. Because as people get hungry, as people's economic ability to make money and to move around are restricted, people will react, and we will be faced with some very difficult decisions coming forward. Do we prioritize low caseloads or stabilization of communities? And so to help with that, we're working with the partnership here to provide some senior ethical and political guidance around the partnership to help us answer some of those very difficult questions that we think will come up, which is, what do we choose? Do we choose less cases and more stability, more economic activity? There's going to be some very challenging questions and decisions ahead.
Yeah,
thanks,
Amanda, that's really a very valid point, and I also like the point that Dalia raised earlier. I think this is really going to be a critical piece, especially for the urban areas and slums. We know, predominantly that most of the population in Africa is rural, so there might be some advantage in with working with community leaders in ensuring that these measures are working in this rural population. But I think in urban and peri-urban areas and some countries, I think like Uganda, even Kenya, are giving some rations of food, because I think there are people who survive, they work in these markets and they only survive by going to those markets to work and get food for that day. So if governments start thinking about that, which other essential services they would provide, and then in terms of for people to access something to eat, and then having waivers and exemptions so that people access medical services when they are sick, especially emergency medical services. I think these are things that policymakers need to be considering. I also think the point that we've seen also, and I think Amanda, the point you raised, the brutal lockdowns are going to have a negative spillover effect, because once people are really pushed in the corner and they are just being battered, they are going to take on some of these. So I think, again, that's some kind of dialogue that we need to be having to ensure that whatever the lockdowns, that they are really implemented with human rights approach and with dignity of individuals being taken forward. Over to you.
Thank you. We only have a minute or two left, so I want to give the panelists an opportunity to say any final remarks before turning it over to Jobin.
Whom do you want to start?
Okay, let me start. I think my final, these NPIs, whatever we're calling them, they are really going to be important. They're important in flattening the curve, as we said. But by and mind, we really, they have to be implemented along with all the other measures. And I really look at aggressive containment measures in terms of rapid identification of cases, isolation, supported by quarantine of contacts. And again, this should be really the measures that have simple ones that we can do, simple hand washing and respiratory etiquette. So these measures they should really be holistically implemented with all the other biomedical measures that we're recommending. So it's not a one size fits all. We might have to look at scenarios where they have to be tweaked to suit the context, to suit the African context in terms of our rural urban settings, and seeing where they might impact negatively most to see that those people are not negatively impacted. Thanks again for allowing us as WHO Afro to participate in this session, and I really thank the participants, over close to 200 who participated in this. Over to you.
Dr. Samori, would you like to go next?
Yes, couple words only. And thank you very much, Amber. I think what he said is exactly what I wanted to elaborate or to emphasize on. It's really very important that when you look into the different non-pharmaceutical measures or the physical distancing measures that need to be implemented in any community, these should not be looked at in isolation, testing and isolation and in quarantine, etc. But two major components, if you want, and basically on these physical distancing measure, and I don't want to repeat my words, but the fact that we still have a little evidence on this area of work, I think it's important to understand that there might be changes over time as long as we collect evidences and on the approaches and the advices that we give to countries. This is one. And two, I think we are all open to innovative approaches and innovative ideas. So maybe we need to start listening from people who are on the ground. What does it exactly mean to them physical distancing? And if they are in a place that they have to abide by, what are the alternatives that it can be taken into consideration to make it easier for them to accept it. So the community acceptance is very important if the government is deciding on different aspects of these physical distancing measures. But in order to guarantee the acceptance of the community, alternatives have to be added in terms of social alternatives, economic alternatives. It might be really difficult to some communities or to some countries to adapt different alternatives, given the fact that some of them, and if not the majority, are low-income countries. But this is where we really also need to stress on the fact that countries have to support each other. And again, under Article 44 of IHR, countries really need to support each other when it comes to public health emergencies. And this can be technically, financially, or logistically, but also it can be by sharing good practices and by sharing examples that they can adapt and make it of use to their own communities. So this is only the start. Thank you very much for organizing this. And I believe that other sessions will be organized, and that will be different forums to share experiences as well. Thank you.
Amanda and Womi, do you have a quick 15 to 30 seconds?
Okay, from Womi. Amanda? Okay, Womi then.
Womi. Go ahead.
All right. Okay, so final words. I think we really need to think about NPIs, implementing social measures along the line of adaptability, along the lines of involvement of those who, the community, those who will be impacted by any means, communicate proactively, maintain that communication, identify early signals to negative effects, and then deal with them specifically. And from the Africa CDC perspective, this is what we've provided is some guidance based on existing knowledge, which is really limited. So we welcome everyone in the community to contribute to the science and evidence of this, and we are happy to keep this conversation going. We learn, we build. I will repeat this again. We are building as we are learning, and this is really an opportunity for us to not just have science, but also help our people and continually save our population.
Yeah, I just want to thank the partnerships and everyone that's contributed, including those that you didn't hear from today for the World Economic Forum, London School, and Ipsos. They've been fantastic in helping us pull this together. We hope that working together in the provision of at least some monitoring data and sharing of lessons, we can help countries make better decisions around this. But just to emphasize what Dr. Frieden really said at the start, there is no time to waste. We need to learn the lessons from the other countries. We don't know what this will look like in Africa with a lower average age and less non-communicable diseases, but with other risk factors like overcrowding, poverty, and malnutrition. And so there's still a lot to learn here. And so we will continue to partner with you as we learn more, both from the public health side and the social side, and work together to see how best we can adapt the lessons from other countries into the context where you're working. So I look forward to collaborating with you all, the partners on the line and the participants on the phone, to learn together. And we appreciate your feedback and all of your questions. Jobin will send out a number of documents, including the PDF of this slide deck and the evidence review I mentioned. And we'll continue to keep you updated on the progress of the monitoring products that we're developing. And we look forward to working with you.
Thank you, Amanda. Just to touch on build on what Amanda just said, today we were able to answer maybe a good portion of many of your questions. We weren't able to get to all of your questions, but thank you so much for sharing this, because we're learning from this perhaps more than you are learning from the experts on the panel. We're learning with you and from you. So we're actually documenting all the questions that you shared with us, and we'll look to a way to best respond to this with some FAQs and the kinds of tools that would be most useful for you. And as Amanda mentioned, as a follow-up to this call today, you can expect the ACDC guidance that Womi talked about, the NPI evidence document that Amanda spoke about, and then we'll also look to sending you the slides and the recording from today's session. Thank you very much to everybody for participating. Hope you have a good rest of the day or a good evening. Thank you.